Good day, class. Today I'll talk about the neoplasms of the lungs. This lecture is lifted from Harrison's Principles of Internal Medicine 20th edition and only tackles the general aspects of the disease. I deeply and strongly advise you to read the chapter for your exams. Okay, let us begin. Lung cancer is uncommon below age 40, with rates increasing up until age 80. The projected lifetime probability of developing the disease is estimated to be approximately 8% among males and about 6% among females. The incidence varies by racial and ethnic groups, with the highest age-adjusted incidence rates among African Americans. Cigarette smokers have a tenfold or greater increased risk of developing lung cancer compared to those who have never smoked. The risk from ETS or environmental tobacco smoke, or what we call secondhand smoke, is less than from active smoking, with about a 20 to 30 increase in lung cancer observed among never smokers married for many years to smokers, in comparison to the 2,000% increase among continuing active smokers. Although cigarette smoking is the cause of majority of lung cancers, several other risk factors have been identified, including occupational exposures to asbestos, arsenic, ether, chromium, mustard gas, nickel, and polycyclic aromatic hydrocarbons. The risk appears to be higher among individuals with low fruit and vegetable intake during adulthood. This observation led to the hypothesis for the chemopreventive effects of retinoids and carotenoids. However, randomized trials failed to validate this. Wala siyang proof. Ionizing radiation is also an established carcinogen, most convincingly demonstrated from studies showing increased rates of lung cancer among survivors of the atom bombs dropped on Hiroshima and Nagasaki, and large excesses among workers exposed to alpha irradiation from radon in underground uranium mining. Prolonged exposure to low-level radon in homes might impact a risk of lung cancer equal or greater than that of environmental tobacco smoke. Prior lung diseases such as chronic bronchitis, emphysema, and pulmonary tuberculosis have been linked to increased risks of lung cancer as well. Certain genetic polymorphisms of the P450 enzyme system, specifically CYP or CYP1A1, and chromosome fragility are associated with the development of lung cancer. History of lung cancer in a first-degree relative have a 2 to 3-fold excess risk of lung cancer and other cancers, many of which are not smoking related. Individuals with inherited mutations in P53 and RB genes may develop lung cancer. Genes that regulate acetylcholine nicotinic receptors and telomerase production are also associated with the disease, as well as these three loci identified in genome studies. The rare germline mutation T7090M involving the epidermal growth factor receptor or the EGFR and susceptibility locus in chromosome 6q may be linked to lung cancer susceptibility in never smokers. WHO classification system divides epithelial lung cancers into 4 major cell types: small cell lung cancer, adenocarcinoma, squamous cell lung cancer, large cell carcinoma. The latter 3 types are collectively known as non-small cell lung cancer. So there are 4 with non-small cell lung cancer for the latter three types. It also helps in differentiating primary from metastatic adenocarcinomas. TTF1 is positive in over 70% of pulmonary adenocarcinomas and is a reliable indicator of primary lung cancer, provided a thyroid primary has been excluded. However, a negative TTF1 does not exclude the possibility of a lung primary. TTF1 is also positive in neuroendocrine tumors of pulmonary and extrapulmonary origin. Napsin A is an aspartate protease that plays an important role in maturation of surfactant B7 and is expressed in cytoplasm of type 2 pneumocytes and has been reported in more than 90% of primary lung adenocarcinomas. Taas. Notably, a combination of Napsin A and TTF1 is useful in distinguishing adenocarcinoma, squamous cell lung cancer, and small cell lung cancer. For primary lung adenocarcinoma, Napsin A is positive and TTF1 is positive. For primary lung squamous cell carcinoma, Napsin A negative, TTF1 negative. And for primary small cell lung cancer, Napsin A is negative and TTF1 is positive. Cytokeratin 7 and 20 used in combination can help narrow the differential diagnosis. Non-squamous, non-small cell lung cancer, small cell lung cancer, and mesothelioma may stain positive for CK7 and negative for CK20. While squamous cell lung cancer will often be both CK7 and CK20 negative. P63 is a useful marker for the detection of non-small cell lung cancers with squamous differentiation. Mesothelioma is difficult to differentiate from adenocarcinoma. The following markers are useful and stain positive for the disease. Use slide. Okay. Lung adenocarcinomas can arise when tumors express mutant EGFR. These same tumors display high sensitivity to small molecules EGFR tyrosine kinase inhibitors. These TK inhibitors, yun yung tablets, yun yung gamot, or what we call targeted therapy. Additional examples of driver mutations in lung adenocarcinoma are the following. Excuse me. Among lung cancer histologies, adenocarcinomas have been the most extensively catalogued for recurrent genomic gains and losses as well as for somatic mutations. This figure shows the driver mutations in lung adenocarcinoma. Just be familiar with the figure. Of course, you memorize the most common and be familiar with the rest. Although driver mutations have mostly been found in adenocarcinomas, potential targets have been identified also in squamous cell carcinomas. This table, lifted from Harrison's, lists the driver mutations in non-small cell lung cancer. Again, try to memorize kung kaya. If not, be familiar with them, pero memorize nyo na. Kaya nyo yan. The prototypical lung cancer patient is a current or former smoker of either sex or either gender, usually in the 7th decade of life. A history of chronic cough with or without hemoptysis in a current or former smoker with chronic obstructive pulmonary disease, age 40 years old or higher, should prompt investigation even with normal chest X-ray findings. Same as with persistent pneumonia without constitutional symptoms and unresponsive to repeated courses of antibiotics. Lung cancers arising in lifetime never smokers is more common in women and East Asians. They also tend to be younger than their smoking counterparts. So even if hindi ka naninigarilyo, you can still develop lung cancer. Majority of patients present with signs and symptoms, laboratory abnormalities that can be attributed to the primary lesion, local tumor growth, invasion or obstruction of adjacent structures, growth at distant metastatic sites, or a paraneoplastic syndrome. The following table tabulated the presenting signs and symptoms of lung cancer with cough, weight loss, and dyspnea as the top 3 most common. Again, no need to memorize everything, but it helps to be familiar with them. Although I suggest to memorize the top 8 to 10 if you can. And since parang 12 lang sila, memorize nyo na lahat. This table shows us the clinical findings suggestive of metastatic disease. Those two tables are found in the latest edition of Harrison's. I leave it to you to read and be familiar with them. Patients with central or endobronchial growth may present with the following, while those with peripheral growth may present with pain, dyspnea, and symptoms of lung abscess due to the mechanisms as shown in the slide. Regional spread of tumor in the thorax by contiguous growth or by metastasis to regional lymph nodes may cause tracheal obstruction, esophageal compression with accompanying dysphagia, recurrent laryngeal paralysis causing hoarseness of the voice, phrenic nerve palsy with elevation of the hemidiaphragm and dyspnea, sympathetic nerve paralysis with Horner syndrome. Horner syndrome is enophthalmos, ptosis, meiosis, and anhidrosis. Malignant pleural effusions can cause pain, dyspnea, or cough. Pancoast or the superior sulcus tumor syndromes result from local extension of a tumor growing in the apex of the lung with involvement of the 8th cervical and 1st and 2nd thoracic nerves. Present with shoulder pain that characteristically radiates in the ulnar distribution of the arm. So ulnar nerve distribution yung pain, characteristic niya. And often with radiologic destruction of the 1st and 2nd ribs. So remember that. Shoulder pain, ulnar nerve distribution, then masisira yung 1st and 2nd ribs. Often, Horner syndrome and Pancoast syndrome coexist. Other problems of regional spread include SVC syndrome or the superior vena cava syndrome from vascular obstruction, pericardial and cardiac extension with resultant tamponade, arrhythmia, or cardiac failure, lymphatic obstruction with resultant pleural effusion, and lymphadentic spread through the lungs with hypoxemia and dyspnea. In addition, lung cancer can spread transbronchially, producing tumor growth along multiple alveolar surfaces with the following effects on the patient. Constitutional symptoms may include the following. Apart from the brevity of symptom duration, these parameters fail to clearly distinguish small cell lung cancer from non-small cell lung cancer or even from neoplasms metastatic to the lungs. So no one symptom or combination of symptoms can differentiate clinically the two major types of lung cancer or even metastasis to the lungs. We need other imaging techniques, and of course, biopsy. Paraneoplastic syndromes are common in patients with lung cancer, especially small cell lung cancer, and may be the presenting finding or first sign of recurrence. In addition, it may mimic metastatic disease and, unless detected, may lead to inappropriate palliative rather than curative treatment. Often, the syndrome may be relieved with successful treatment of the tumor. Systemic symptoms of anorexia, cachexia, weight loss, seen in about 30% of patients. Fever and suppressed immunity are all paraneoplastic syndromes of unknown etiology. Weight loss greater than 10% of total body weight is considered a bad prognostic sign. Endocrine syndromes are seen in 12% of patients. Hypercalcemia resulting from ectopic production of parathyroid hormone or PTH related peptide is the most common life-threatening metabolic complication of malignancy, primarily from squamous cell carcinomas of the lung. So, ulitin ko, hypercalcemia, most common life-threatening metabolic complication of malignancy. Hyponatremia is secondary to secretion of antidiuretic hormone, SIADH, or atrial natriuretic peptide, ANP. SIADH resolves within 1 to 4 weeks of initiating chemotherapy in vast majority of cases. Serum sodium can usually be managed and maintained above 128 milliequivalents per liter via fluid restriction during treatment. Demeclocycline can be a useful adjunctive measure when fluid restriction alone is insufficient. Cushing syndrome results from ectopic secretion of ACTH by small cell lung cancer and pulmonary carcinoids. Usually results in additional electrolyte imbalances, especially hypokalemia. Standard medications such as metirapone and ketoconazole are ineffective due to extremely high cortisol levels. The most effective strategy for management of Cushing syndrome is effective treatment of the underlying small cell lung cancer. Bilateral adrenalectomy may be observed in extreme cases. Kaya, for paraneoplastic syndromes, ang technique is to treat the underlying cause or the cancer itself. Tissue sampling is required to confirm a diagnosis in all patients with suspected lung cancer. A core biopsy is preferred to ensure adequate tissue for analysis. Tumor tissue may be obtained via minimally invasive techniques such as bronchial or transbronchial biopsy during fiber optic bronchoscopy, fine needle aspiration or percutaneous biopsy using image guidance, and endobronchial ultrasound guided biopsy. In patients with suspected metastatic disease, diagnosis may be confirmed by percutaneous biopsy of a soft tissue mass, lytic bone lesion, bone marrow, pleural or liver lesion, or an adequate cell block obtained from a malignant pleural effusion. In suspected malignant pleural effusion, if the initial thoracentesis is negative, a repeat thoracentesis is warranted. Although the majority of pleural effusions are due to malignant disease, particularly if they are exudative or bloody, some may still be parapneumonic or caused by pneumonia. In the absence of distant disease, such patients should be considered for possible curative treatment. Kaya wag automatic, hindi porket may tubig sa baga, metastatic disease na yon from a lung cancer. Pwedeng pneumonia lang kasi. Now we go to staging. medyo mahirap. The following table is lifted from the NCCN guidelines, or the National Comprehensive Cancer Network guidelines, which in turn is from the AJCC Cancer Staging Manual 8th edition. Staging of non-small cell lung cancer is dependent on the size of the primary tumor, the number and location of lymph nodes involved, and if metastasis to distant organs is present or not. This is what is called the TNM staging. T for tumor, N for lymph nodes, and M for metastasis. Basically, the larger the tumor and more extensively destructive locally, the higher the T grade. The greater the number and more extensive the lymph node involvement, the higher the N grade. Distant metastasis acquires an M1 grade. So, ang metastasis is M0 or M1 lang. The combination of the T and M grade sets up the stage of the disease. No need to memorize. You just have to know the pattern. For example, M1 grade is automatic stage 4. For N1, automatic stage 2B siya. N2 naman, automatic stage 3A. Kapag N3, at least stage 3B siya. For T1, at least stage 1A. T2, at least stage 1B. T3, at least stage 2B siya. And for T4, at least stage 3A. No? It's a little bit perplexing at first, but if you just look at the pattern, ganun ako nag-memorize yan eh. Kaya naman, kaya yan. Pero if you want, you can memorize the whole thing. Pero ako, pattern lang ang tinitingnan ko. Now we go to staging of small cell lung cancer. Staging of small cell lung cancer is a bit different. It is recommended that the Veterans Administration System and American Joint Committee on Cancer, or the AJCC, International Union Against Cancer 7th Edition System, be used to classify tumor stage. The Veterans Administration System is a distinct two-stage system dividing patients into those with limited or extensive disease. Dalawa lang, limited or extensive disease. Limited stage disease have cancer that is confined to the ipsilateral hemithorax and can be encompassed within a tolerable radiation port. Radiation port, yun yung ginagamit sa radiation oncology. Yung mga radiation oncologists natin to treat the disease. Kapag kasya sa isang port, standard port, limited lang siya. Kaya, contralateral, supraclavicular nodes, recurrent laryngeal nerve involvement, and superior vena cava obstruction can all be part of limited stage disease kung kasya. So, as long as kasya dun sa radiation port, limited stage lang siya. Excuse me. Extensive stage disease have overt metastatic disease by imaging and physical examination. Cardiac tamponade, malignant pleural effusion, and bilateral parenchymal involvement generally qualify disease as extensive stage disease because the involved organs cannot be encompassed safely or effectively within a single radiation therapy port. 60 to 70% of patients are diagnosed with extensive disease stage at presentation. So, malaki. The TNM staging is preferred in the rare small cell lung cancer patient presenting with what appears to be clinical stage 1 disease. Accurate staging of patients with non-small cell lung cancer is essential in determining the appropriate treatment in patients with resectable disease and for avoiding unnecessary surgical procedures in patients with advanced disease. Treatment of any other type of cancer needs a treatment of any type of cancer needs multidisciplinary team approach. This is for the benefit of the patient. The team consists of different specialists and health personnel that is essential in the proper management of the patient and the disease, of course. For N0 or N1 nodes, surgery is an option and is part of the treatment. Under this, those with stage 1A and stage 1B, less than 4 centimeters, surgery alone is not enough. Surgery alone is enough for stage 1A and stage 1B less than 4 centimeters. However, for stage 1B, more than 4 centimeters up to stage 2 or 3, surgery is followed by adjuvant chemotherapy. For N2 or N3 nodes, surgery is no longer an option. Treatment involves combination of radiation therapy and chemotherapy. For metastatic disease, systemic therapy is the preferred management. For non-small cell lung cancer patients with metastatic disease, systemic therapy can involve the newer agents such as targeted therapy and immunotherapy, not just chemotherapy. Applicability of these newer agents depend on the presence of mutations from the specimen collected. This table summarizes the mutations and tests that are done, as well as the agents for that specific abnormality. These agents are, in general, better tolerated by patients and, according to studies, have better outcomes as compared to chemotherapy for these patients. Testing of these mutations also depend on the histology. For squamous cell lung cancer, PDL1 is the only one tested, as compared with non-squamous histology, wherein EGFR, ALK, and PDL1 are recommended to be done. EGFR is for agents such as erlotinib, afatinib, and gefitinib. ALK is for crizotinib, and PDL1 is for pembrolizumab. If ever the tests done are all negative, we are left with chemotherapy plus or minus the monoclonal antibody bevacizumab, depending on the histology. Now, I will try to explain the mechanism of action of pembrolizumab. It is a monoclonal antibody used in cancer immunotherapy. Cancer cells are smart. They do things so that they can live longer, spread, and wreak havoc on our poor patients. One of their technique is to suppress the body's own immune system so that they will not be identified and killed. They do this by attaching to T-cell lymphocytes. Once attached, the T-cell is suppressed and is of no use in killing tumor cells. Here in the figure, we can see the PDL1 and PDL2 arms of tumor cell attaching to the PD-1 receptor. PDL stands for programmed cell death ligand, or yun yung protein. PD receptor stands for programmed cell death receptor. So PDL1, siya yung protein na mag-a-attach dun sa PD receptor. So one can say that they are made for each other. Parehong-pareho ng pangalan. Fortunately, we are smarter. Scientists and research studies came about with pembrolizumab. It acts by blocking the PD-1 receptor in lymphocytes. Hence, the nasty ligands of the tumor cells cannot attach to the receptor since they are already occupied. Then, the very happy T cell can now go about its business in killing tumor cells. Okay, so si pembrolizumab mag-attach sa receptor. wala na magagawa yung tumor cells. We now go to the treatment of small cell lung cancer. Treatment also depends on the stage of the disease. If metastatic already, chemotherapy alone and or radiation therapy is given for palliation. If non-metastatic, the combination of chemotherapy and radiation therapy, either sequential, magkasunod, or combined, sabay, are treatment options. I guess this is my last slide. This last slide summarizes the medications that can be given to non-small cell and small cell lung cancer. Chemotherapy, targeted therapy in the form of tyrosine kinase inhibitors or the TKIs, and immunotherapy using already discussed monoclonal antibodies. I guess that's it. I am Dr. Pinzon of the Section of Medical Oncology, Department of Internal Medicine. Thank you for listening. Stay safe and strong, FEU.